I think we'll leave it right there. I think it was Stephanie that said the 49 years were the tough ones, not Rodney. Today our program is going to be presented by Dr. Dominic Glorioso. Our speaker that we had coming from California obviously couldn't make it through Sandy on the last couple of days, but Dominic has very graciously supplied the program for today. We're going to talk about palliative care medicine, which is new to many of us. It's something that we don't think of often. It's care that's given to not only the patient, but the family and all those surrounding the patient. It's talking about the patient, not the disease. The disease is managed by other people. Dr. Glorioso studied in college in Philadelphia, LaSalle, and went to Philadelphia College of Osteopathic Medicine, where he completed his internal medicine residency program. He's been in York County for the past about 15 years and is now practicing in Dover. And I'd like you all to give a good warm Rotary welcome to Dominic Glorioso. Thank you, Dr.
Good afternoon. Dr. Van Goot, who was supposed to speak today, he's a pioneer in hospice and palliative care medicine, but like was said, because of the hurricane, he couldn't make it. Obviously, this hurricane is a very serious topic. I have friends who live in New York City. I have friends who live just outside Atlantic City and are going through a lot of hardship right now. I hope me speaking to you for about 25 minutes doesn't go on that list of hardships because Sandy either. Okay. This is a very serious topic, but it's good to laugh, and laughing in no way means that you're being disrespectful. Every day we see families going through very tough times, and I think a little bit of humor is very helpful. I just have to say right off, I'm so excited that an organization like this has taken an interest in this topic. I have a couple of slides toward the end that talk about what an organization like this can help to do for a community. All right, so our objectives, every time I get a talk, they say, well, what are your objectives? What are you going to talk about? Well, I'm going to talk about what palliative care is. I'll also explain about advanced directives. So that's something that needs to be done, not just at the hospital level, but also in the church and community level. And then I'm going to talk a little bit about things that an organization such as the Rotary can do to try to help with some of these objectives as well. So when we look at our healthcare system, do we have a problem? No matter what political affiliation you have, things have to change, and things are going to change, and it would be nice if we had some kind of plans to help with that change. Now, every time this talk is done, people start with some horrible slides to tell you how bad things are. So I'm just going to do a couple of these. And this is a slide on healthcare costs, and on the left side is dollars, and on the bottom is the age. And as you look, most countries go up slightly as you get about 55 or 60. So, before that, we should be putting money into disease management, lifestyle changes, maybe preventative medicine. But what happens in the United States? Well, not so surprising. Our line is a little bit different than the other countries. Way, way, way up. Boom. And why is that? Are we getting in healthcare what we're putting into it? Well, maybe not. A third of all Medicare spending occurs in the last year of life. So no matter how good we are at managing diseases, as far as I know, everybody is still going to pass away. So we need to do a better job. Even if you don't have a disease, you're going to die. As this great historian once said, is that what he is? How some of us are going to feel foolish lying in the hospital dying of nothing. All right, I'm going to show one more slide. So we do put a lot of money in it, but we get a lot for that. Well, this is a slide looking at costs and looking at longevity. What's the life expectancy? And I don't think my pointer's working, but you want to be like in that left upper corner where you're not spending a lot of money and living a lot. I don't know if you can make out Japan there, up there. So how do we do in the United States? Well, I don't think I'd surprise anybody if our little guy in a wheelchair goes all the way to the end as far as spending the most money. But how about his life expectancy? How far high? Well, we don't get that high. We're about up there with Greece. So we need to be doing a better job in taking care of people, but also not wasting so much money either, and things that are really going to help people and probably are hurting them. So hospice and palliative care is a concept that was new to York County about 7, 8 years ago. And some colleagues of mine have helped to get this established. But when we got there, people kind of had some preconceptions about what we did. First of all, somehow they thought we were going to be doing physician-assisted suicide and euthanizing people. That's not what we do. Getting palliative care involved is not giving up. And I have, there's some data that shows that people actually do better and live longer when palliative care is involved early on. We do use medication to keep people comfortable, but that's the only reason that we use them. Sometimes we get called in very late. I've gotten called in to see people after the gift of life, which is the organ donation. People have to look into the family. There's really nothing I can do at that point. And then sometimes we've been called the death squads. Because we do deal with people that are dying, but we're certainly not the death squad in forcing any type of restrictions on their health care and what they receive. I think it's easy to say that we have shortcomings in what we do, especially in individuals that are seriously ill. A lot of physicians don't lack, or do lack the knowledge on how to not only communicate effectively with patients and their families, but also to manage symptoms such as pain and nausea. Doctors don't talk to patients very well. Patients don't talk to doctors very well. And sometimes we use things that are very aggressive at a time when we shouldn't be doing things that are so aggressive. This was a study, and I can't read that bottom line, but it was a study looking at how we took care of people. And it was a big study that was done about 1997. They spent quite a bit of money on this study, 4,000 patients, and they learned two things from this study that stood out. Half the doctors didn't even know if their patients wanted CPR or not. And if the patients died in the hospital, for a good amount of the time that they were in the hospital, they were having pain. So there's some kind of a loss in what we're doing. I think we're spending a lot of effort treating diseases, not enough effort treating patients. And this is an old cartoon, some of you might recognize it. It says, "We have met the enemy, and he is us." One of the problems with looking at a study like this is to say, that's not our hospital, that wasn't happening here. When it was happening, this was a representative group of hospitals, and we have to look at these problems too. So death and dying in America. There's a disparity between the way people do die and the way they would want to die. Most would rather be home. Most would be interested in a program such as hospice. If I talk to people, this is how they want to pass away. They want their family there, their friends there. But too often they wind up ending like this in an institution. And more than once I've heard families say, if we would have known, we wouldn't have done this. So where do people die? Mostly in a hospital, 25% or so in a nursing home, and about another quarter at home. So I actually met this guy a couple of weeks ago. He was in Montreal. But about 30 years ago, in the hospital he was working at, he saw that there was problems in the way people were being taken care of. It didn't seem like it was patient-centered. It looked like their symptoms weren't well controlled. And mainly, there wasn't any discussion with the patients and their families about what to do or what can be done. So he was the one who gave us this odd name called Palliative Care. And palliate means the comfort or the cloak. And he first started this in the 70s in his hospital in Montreal. And palliative care seeks to prevent, relieve, reduce, or soothe the symptoms of diseases without affecting the cure. People can still be receiving treatment. People often are still receiving treatment when we get involved. Our goal is to help them get through the treatment and then whatever else is left. It can be needed at any time in the disease directory, so sometimes we get called very late, but we can be called at any time, even at diagnosis. We do a couple different things. I stole these slides from Dr. Van Newton, so don't tell him, right? But what do? Well, we do have a consultation service in the hospital. We help with the care of patients that are in the hospital. Other doctors ask us to help with some of their patients. We have an outpatient office where we see cancer patients and other patients with illnesses that aren't going to go away, and we help deal with them and their families too. We like to branch out and do more home care and even in nursing homes too. So we try to see ourselves as trying to help people any place where they are so that they get the right type of care. Our goal is to improve pain and symptom control. Prognosticate is a fancy word that says, when patients ask us, how long do I have to live? Doctors are lousy at this. They tend to overestimate, sometimes by a factor of up to 5. So if you have only 1 month to live, the doctor will say you have 5 months to live. And that might be, because he's trying to be nice, but a lot of times it's because we believe that we just don't do a good job. While we don't want to give people bad news all the time, we do want to prepare them so that they can make their proper plans. Communicate. And again, that goes both ways. Not trying to explain what the doctors are saying to the patient, but also explaining to the doctor what the patient really wants and what's important to them. We'll talk about advanced directives a little bit later on. So, what is palliative care? This is a kind of a chart that pretty much every lecture I've ever been to on palliative care has something similar to this. I changed it around a little bit. And the idea is that you would do all you would normally do for an illness, and when there's nothing left to do, when you've completely exhausted every possible way of treating this patient, then you would get us involved. So we would see dead people. I don't know if anyone's a fan of The Walking Dead. That's from. All right. So a better view would be if somehow, perhaps as we're losing options, then maybe get us involved so that we can become a more important part of their care. But really what we've been doing over the last couple of years is really stressing that we should be involved early on in these cases. There should be no demarcation between the standard care that they're receiving from the other doctors and what we do. We should be working together. So maybe to add another couple of definitions. It's comprehensive care for all patients, including those pursuing life-prolonging treatments. And not simply a sequel to failed care, but a synchronous synergistic component of medical treatment. More and more we're getting involved very early in care, especially in patients that are very sick. Patients, for example, in the intensive care unit. So people say, well, what's the difference between palliative care and hospice? And I think the easy definition is probably the better one, where hospice is the last 6 months of palliative care. Now, if I could predict when people were going to pass, I would hope I would have other predictive skills such as the racetrack, the election next week, but I don't. So all we can do is try to get an educated number about when somebody does get into that category of 6 months or less. And certainly people live much longer sometimes in hospice than 6 months. And we provide support and care for terminally ill, but the big thing is also for their families. A lot of times the families are put in charge of taking care of this patient, even when we're involved. We're not there 24 hours a day, 7 days a week. A lot of the care is done by the family, so we need to support the family when we do hospice as well. We stress palliative care, the things I talked about as far as symptom control and communication, but we also try to meet physical, psychosocial, and spiritual needs. All hospices have social workers. All hospices have chaplains that can help us under these problems. And the big emphasis is trying to keep the patient at home if that's where they want to be. Our settings, when not at home, we do see people in the hospital and nursing homes, assisted living. We try to go to where they're living and try to keep them there if we can. I alluded to this. We have meetings, and we do this in palliative care and in hospice. And at least once a week, we have a meeting where we have all the team members there. And this includes all kinds of medical people, from pharmacists to social workers to therapists. The idea is these people have complex problems, and not one person can solve them. You have to get a team involved and try to address them. Not all the patients in pain need pain medicine. There may be some social problems, and they're worried about their family or what's going to happen when they pass. So our approach is a team approach, which for some people, some physicians, is not something they're comfortable with. And then some of the terminal diagnoses that we see, besides cancers, are things like Alzheimer's disease, and any of the diseases. These are a lot of abbreviations for diseases, but it's any of the end-stage heart disease, lung disease, kidney disease. When I got involved in palliative care, the big disease I took care of was AIDS. And these people, 20-some years ago, 30-some years ago, had a death sentence. Their disease was much like cancer is, where once they met certain criteria, we knew that there was going to be a year or two for them to live. And I got involved because the infectious disease doctors that were managing didn't have any skills on how to manage the other problems that they had as far as their symptoms and the communication. AIDS has not even been assessed anymore, although we going to shift gears here and talk about another topic, and this is about advanced directives. And basically, you have a written plan to say what you want your health care to be like if you can't speak for yourself. It's a legal document. Are there any lawyers in this group? No? Okay. I'll be careful what I say. All right, it's a legal document and it allows you to help with the planning of your end of life when you can't make decisions anymore. One of the biggest hang-ups bringing this up is people say, well, no one wants to talk about that. But there was a study done where 88% of the people said they wouldn't mind having this discussion, not only with their doctor, but with other professionals. I kind of liken this to a pretty girl that doesn't get asked for prom. You know, people just kind of assume you don't want to talk about it. Some of the longest conversations I've had with people are people who initially told me they didn't want to talk about it. So who has advanced directives? Well, if you ask like how many people in Pennsylvania have, and the number's going to be really low, because, you know, it takes in adults and anybody over 18. But you would think, you know, maybe once you were given a bad diagnosis such as cancer, that this number would go up to be very, very, very high. Well, it goes up a little bit, but not that high. Well, certainly the doctors and nurses taking care of cancer patients, they know better. So you would think a very, very high percentage of them would have advanced directives, but not as though that much higher either. Still a problem, but there are some communities that do a better job. It's the elephant in the living room. I'm right there in the room, and no one even acknowledges me, is what this says. It's something that people don't want to talk up, but it's something that you should. There are different approaches for this, and the one that I find the least favorite is when you ask somebody and they say, well, my family knows what to do. So then it comes where I have to ask the family, and guess what? They don't know what to do. Talk about those documents is good, at least you talked about it. I think the documents are helpful in supporting the people left to make decisions. I think it gives them a little bit of confidence that they're doing the right thing. One of my other favorites is no talk that they did complete advanced directives. So then when I call somebody and ask them, they have no idea what I'm talking about. The best way would be to do talk and also then put something in writing, which is what the advanced directives does. One of the reasons why we do this, and I explain this to patients, that you probably will be at a point where you're not going to really know that much about what's going on. And really what you're doing this is you're giving a gift to your family. Because we don't want them to go through hardship. We don't want to be fights at the last minute. I've been to a lot of meetings where there's been fighting. It's not because somebody's evil or somebody wants to do something bad. Quite the contrary. Most people want to do the right thing. They're just not sure which way to go, and that's where the conflict is. I might need to have some advance myself. It did work for a while. Well, if somebody, if you can just hit the little arrow there, not waiting for somebody to kind of do that. What I'm going to talk about is who should make end-of-life decisions. Oh, now it's working. And I think goofy pictures for a reason. It should be the patient. And some people recognize these. I show these to residents at the hospital. They have no clue who these people are. So it should be the patient. And for the most part, we try to get the patient to make a decision, but a lot of times they're just too little to do so. Certainly churches are important, and some people have to live by certain rules about what needs to be done at their end of life. The family is also very important. Certainly the doctor. And really, who did make these decisions in the past? It usually was the doctor. Certainly there's laws that we have to look at. And then, this is something that I was very much involved with years ago, where the partner, who may not be married to the patient, didn't have any authority. And I'm not making, I want to say this right now, it's important. Let me just read you as far as I know I get, okay? Now, there wouldn't be anything wrong with that, but I'm not trying to put anything on them. But a lot of times in HIV patients, the partner wasn't somebody that was family or had legal papers. And even though they were probably the one that was most involved in the care of the patient, a lot of times they didn't have any authority to make any decisions. So if it's not the patient that makes the decision, then the patient should be able to pick who should make decisions for him. So in Pennsylvania, there's two types of advanced directives, and usually we do both of them. It's the living will, which describes your wishes regarding medical care, and the durable power of attorney for health care. Basically, the person you appoint and put in writing as to make decisions for you when you can't make them for yourself. So the living will is a document that says what kind of care you would or would not want when you're sick. And for this to come into play, there has to be some things for it to kick in. One is that you have to have an end-stage medical condition. I'll go over what that is. You have to be pretty sick for this to come into play. You have to be either permanently unconscious or at least at the point where you can't make decisions for yourself, which is called being incompetent. So incompetent, again, is just can you make a decision? And it just doesn't mean that you can't have a little bit of dementia, you can't like forget things like where to park or where you park your car, but it doesn't mean that you have to understand what's going on as far as your condition to the point that you can make a decision and have that decision be communicated. Now, sometimes people don't understand what's going on. They may say they don't want something, but they may not realize that without it, they may not be able to live. They may be just too sick to be able to make that decision. So sometimes we'll say that they're not at the point where they can make a decision. We don't have to get lawyers or even psychiatrists involved with this. Usually the doctor taking care of the patient can make that judgment whether or not they think they understand what's going on and can make a valid decision. An end-stage medical condition is usually a bad illness that you're really sick from. You're at a point where people have to take care of you. You can no longer take care of yourself. And even though you may not die in the next few days, you're probably going to die from this illness relatively quickly. And then permanently unconscious, pretty much means what it says, that you're not waking up, nor is there any hope that you will wake up. And, we always say we have to wait an appropriate amount of time, and that varies depending on what has caused you to be unconscious. So in other words, the living will only applies when doing things to you would either prolong the dying process or keep an unconscious person alive with no hope of waking. Any adult can make a directive. Minors who are emancipated can do so as well, but it's mostly adults that do this. And your doctor will use this if he has a copy. But again, as long as you're talking and making your own decisions, these papers mean nothing. It's only when you get to that point where you can't make a decision that these even come into play. So I mentioned the durable power of attorney, and it's not quite that. It's actually durable, meaning that it doesn't fade away. So if you have one of these documents, until you change it, they still good. There's no statute of limitations on these, and that's why they're called durable. And this is the person that you pick that's going to make decisions for you when you can't make them for yourself. So a little advice, pick somebody that likes you. It may not necessarily be your spouse, that's okay. But even more important than that, you want somebody that's going to be able to make decisions the way you would have made them, not necessarily what they think is best or what they think is right or what they would want for themselves, but what you would want if you could sit up and hit them on the head and say, no, this is what I want you to do. A lot of names for it. Usually has the word agent in it, like healthcare agent. Sometimes it's called attorney, in fact. But this is the person specifically that you have put in a document to make decisions for yourself. And I'll explain why that's important a little bit later. Again, someone you trust, someone who understands you, someone who understands your values. But more importantly, someone who's going to make decisions as if you were there and can make a decision yourself. When I talk to people that are durable power attorney, one of the things I try to stress is I don't want you to make a decision. I want you to tell me what your friend, your spouse would tell me if you could talk. Frame it that way. It takes some of the pressure off of it. Because a lot of times they say, boy, I know what he would want. I'm having a hard time saying it. But I know this is what he would want, and I'm going to say it, and I want you to do what he would wish. It's more flexible than living will, where, maybe 20, 30 years ago you wrote what you don't want and you do want. This has the idea, because it's a person we're dealing with, they can look at some of the nuances. As a condition occurs, it's different than when you're thinking about it 20 years ago when you're healthy. And if you can't read it, it says Mexican proverb, the appearance of the bull changes once you've entered the ring. All right. So you ignore me, you don't do your advanced directives, you don't do a power of attorney. So you're sick and you can't speak. So now we've got to find out who's going to make decisions because you obviously can't. You're way too sick. Okay? The first person we would get would be your current spouse, an adult of another relationship, adult child. So this is kind of like the Anna Nicole Smith thing where your adult children had some issues. What comes up next is the adult child of the current relationship, and then it goes parents, adult siblings, adult grandchild, and a close friend afterwards. Again, it's important to put in writing who you want to make decisions. Decision makers, when you pick that way, have some of the authority as a durable power of attorney, but they can only make decisions for you when you're terminally ill or permanently unconscious, not just when you're unable to make decisions for yourself. I'm going to go this a little bit quickly because we're getting toward the end. The big thing is to keep a copy of this somewhere readily accessible. This isn't something you put in the safe that we find out at the reading of your will that you didn't want us to do some of the things we've already done to you. The big thing was this was the power of attorney that you announced in writing can make decisions for you just when you're incompetent. You don't have to be terminally ill. And that's what we would hope, that the person that knows you and loves you will help us get through that point when you're very sick, even if you're going to get well. If the patient is competent, he or she is a decision maker. Sometimes I have to stress this with the doctors and the residents I deal with during teaching, that you don't necessarily go to the spouse. You have to go to the patient first, even if you're sick. Real briefly, I want to talk about a community in Wisconsin, which they decided they wanted to really address this issue about the care of their patients when they're very sick, the care of their citizens when they're very sick, and especially when they're at the end of life. And this is across Wisconsin, and the name of their medical system there is called Gunderson Lutheran. And if you look at the demographics of that community, it's very much like York. There's a high influence of German-American type people, but with some minority representation as well. And this wasn't that the hospital decided to do it, this was the community that decided to do it. The hospital alone, the doctors, the nurses, they wouldn't be enough. So, in that community, most people have an advanced directive. Well over 80, almost 90% of everybody in the community as an adult has that, compared to nationally, I said about 16 to 30%, maybe even be a little bit more optimistic number, where it was almost 40%. But again, having a paper is not important, is not the only thing you have to do. When these people went to the hospital, guess what? The doctors and the nurses and the staff had those papers. They actually look at it and try to figure out what was the best way to do things. And even more important, they actually tried to do what the paper said, compared to about 50% of the time in other hospitals, 90% of the time in this hospital in La Crosse, Wisconsin. So it's not just doing a paper, blindly sticking in a safe somewhere or safe deposit box. It's actually having the doctors taking care of you, know that there's a paper, and those doctors and the staff of that hospital making a commitment to try to follow that. And there was a lot of information on this community about how much happier this community is doing this, how much more satisfied they are with the healthcare system than other parts of the country where they're not very satisfied. But since I know I have some hospital officials here that pay my salary, very generously, I might add. I wanted just to show a slide on cost, and then these will be my last few slides. If you look at lengths of stay, LOS, there on the left, and then the final 2 years of life, how many days do you spend in the hospital in your last 2 years of life? Probably don't want to really be in the hospital that much. Well, in Gunderson Lutheran, it's about 15 days, compared to over 50 days in a place like New York. And you may think that's probably a little bit more expensive. Well, we go from about $18,000 for your last 2 years of life to places like, again, Miami and New York, where that number goes over $60,000, so 3 times as much. And these people do not feel they're getting less care, they feel they're getting better care. So, 3 actions that the Rotary can offer employees in their community. One would be if you work in a corporation and you have some say in the insurance that people have. Over the years I've seen people that have had very poor hospice coverage. Now Medicare already pays for that. These would be people that had the misfortune to still be working when they got very ill. And when you go to talk to them about hospice, their benefit is very, very poor. Maybe just a few $1,000. Was that? Sometimes they may not even be there at all, and there's not a hospice benefit. We would still take care of those patients with hospice, by the way. The other thing is this. I mean, it's the elephant in the living room. Talk about these things. You know, people in the community need to know more about what's going on with their health care. You know, if I can say one good thing that's coming out of the election cycle, and it's a hard struggle to say that, I think people became a little bit more aware of what the problem with the healthcare system is in the United States, and maybe they're looking at it more seriously. The third thing would be, you know, and this, I'm a big proponent of this, and if you want to lecture just on advanced directives, see me afterwards and I can set that up for you. But we should encourage people to do advanced directives. And this has to be done not just in a hospital and a doctor's office, but also in the churches and organizations such as this. And the fourth thing would be to, at some point, look to have freestanding hospice in York. There are some patients that their home life is not good. They don't have the support at home where they can go to stay at their home. It would be nice to have a place where we can send them that would be not a hospital, more like a community place where they can spend their final time on this earth. So with that, I'm going to close. And
since we're running over for a few minutes, Dr. Glorioso, we'll stay for questions if you want to see him at the table. We do have a gift for you.